Now, Penny Lockwood is going to talk to us about her experiences in Japan. Penny's from the Lake District, which is very close to my heart. My family are from the Lake District. I spent a lot of my summer holidays when I was tiny climbing up mountains, freezing on the shores of Wastwater, and eating strange long sausages, generally bought from garden centres, weirdly. And she's going to talk to us about her experiences in Japan. Penny Lockwood. On you come, Penny. Don't say that. Cancel. There you go.
Okay, so global healthcare with a difference. What I'm going to do today is go through the background of what led to me working in Japan for a short while, talk a little bit about Japanese healthcare to try and put it into context, talk about the hospital that I worked in, which was basically a makeshift hospital to provide care to a large population of teenagers and adults looking after the teenagers. Talk about the site that they were on, because it did affect the healthcare that we had to give them, and the activities that the people within that site were undergoing. Talk a little bit about providing primary care. What did I learn that's probably relevant to most of us? So that's sort of the structure of what I'm going to go through today. How did it start? Well, I work with the Scouts, and every 4 years they have an international jamboree, which basically means that Scouts from all over the world congregate in one place. And we're talking about sort of 4,000 to 8,000, and at this particular jamboree it was around about 8,000 participants. That was Scouts and leaders, and that's without the service team that provided care for the Scouts and the leaders. And it was held at Yamaguchi, which is a small town in Japan, and I'll show you that on the map. And as I say, it's Scouts from all over the world. So we're dealing with Scouts and leaders and adults from Scandinavia all the way down to South Asia. So one of the things is that understanding and working with other cultures is strongly encouraged within the Scouts, and that impacted and actually made this experience quite a very good experience to have. The initial remit, I simply was told that I was going to provide medical support because I wasn't licensed, that's all it was. I was going to act as a cultural information for those working on the site. The real remit when I turned up was actually you're going to be seeing and assessing patients, and because you're not licensed, the Japanese doctors will sign off what your decisions are and what management you are going to do for the patient, which was a bit of a shame really, because I turned up without an oroscope, an ophthalmoscope or a stethoscope, which created problems in its own right. Although I spent about 3 weeks in Japan, I was about 10 days on the site itself, looking after the contingent, although again I was there for 2 days beforehand setting up and 2 days after. Everybody was camping, including during the tropical storm that came across while we were there. And then the children disappear off to join other Japanese Japanese families, and they stay with them for another week. And there were some cultural challenges, and there was things that we certainly learnt from each other. So where was it? It's in this area of Japan here. The altitude wasn't very high, obviously it was right next to the sea, and one of the things we were dealing with was the difference in laws. For example, in Japan it can be illegal to swim on some beaches, and you can imagine trying to get multinational teenagers to understand that these are the rules and you should obey them can be quite interesting. And here is, so as you can see, it's on a flat piece of land. This site was actually flooded a week before we went out there, because it was not long after the typhoon that came through. Because of the typhoon, not only was this site flooded, they hadn't been able to erect nearly half the stuff they wanted to erect before we went out. So they were still in the process of building the site as we arrived to set up our care. Consequently, the hospital was in the process of being set up. As you can see, the rainfall normally isn't very much. So, one of the things that surprised me when I went out there was that Japanese healthcare is very much based on Western medicine. I think I had a preconception that would be a lot of alternative medicine involved, but there wasn't. It very much is based on Western medicine. One of the main differences is the patients self-refer directly to the specialists. In fact, there's no real equivalent to GPs within the UK. The nearest they get is once the patients have had a diagnosis and discharged, the family doctors or the equivalents might follow those patients up and do the chronic care, but they don't do any of the initial assessment. And primary care really is public health based, sort of population, disease control, that sort of thing. So all the initial assessments are done in the hospital, and then the consultants from the different specialties will come down and work in A&E. There wasn't an A&E specialist per se. History taking is a little bit different to the type of history taking we do, and the initial assessment is slightly different to the way that we do the initial assessment. And the other major difference is the doses, something I hadn't thought about before I went out there, but where we have 500 milligram tablets of paracetamol, they use 20 milligrams. And as you can imagine, when we came to prescribe for our own population, it caused quite a discussion amongst us and the Japanese as to the doses. And when we talked about it, it was because, on the whole, the Japanese population have less body mass than the European populations, and on the whole need less medication. So for me that was an important point to consider when I've got people, adults, who may be small adults coming through. Perhaps I need to think carefully about the prescribing more so than I do normally. So this was the hospital. That was the main entrance. As you can see, it's tied down because we were aware that this tropical storm was coming. There was air conditioning at this end and air conditioning at this end, which was great, except the doors were propped open to let the patients come in, so it was actually turned into a very hot environment, and it was one large hut that was partitioned off by temporary walls. It changed as the 10 days went on, again as we learnt from each other. And this was the medical team. This was a public health consultant who did an awful lot of work setting up the hospital. This was a consultant cardiologist, and this was myself, and we tended to be on the same shift. This was another cardiologist that worked in the hospital, and these red tops were the uniforms. We either had an orange top or a red top, and it basically said you were medical staff. And one of the challenges was medical could range from consultant GP down to, not down, but across, I should say, to pharmacy, nursing staff, etc. So it was sometimes very difficult to work out who was doing what role. And then down here is a multinational team. This lady's a pharmacist from the UK. This gentleman's an American, sort of family GP equivalent. This gentleman's from Malaysia. He was a cardiologist. This is a gastroenterologist from Sweden. Myself, obviously, and this is gentleman's a Canadian family doctor. But in Canada, family doctors are really quite different to the family doctors here in that they have a much bigger, wider remit. They still deliver babies over there, and they still provide a lot of care that here would be provided at secondary care level. So it made it a very interesting environment to work in. And we've just called that, we three were the main ones that were on together, that could share English as a common language. So, challenges, obviously not licensed. I found it quite challenging as a GP with quite a few years of experience behind me to have to come down to the level of presenting my case to another doctor who would then decide if they were going to agree with your treatment or not. And obviously there was a challenge because there's cultural differences in understanding of how you manage and look after conditions. The hospital, because it was set up by public health, they hadn't considered things which we would consider basic medical equipment. As soon as they realised it was needed, then obviously they agreed it was an issue, and sometimes they could get the things and sometimes they couldn't. So thermometers, ophthalmoscopes, oroscopes, stethoscopes, sphygmometers, all those things had to be brought in later on when it was highlighted this was equipment that was needed. So there was a few equipment problems. Doug, the Canadian, was great because he'd been to a previous jamboree, so was aware this might be a problem, and he had a great box of stuff which was constantly raided. As I say, the Japanese colleagues signed our prescriptions, so sometimes there would be a debate. There are certain prescriptions that we would have that they don't have, and things that they use that I would never dream of using. As I say, I wasn't aware of providing medical care until I arrived. There was no triage. Now, on a shift, you might have 3 doctors there and maybe 2 or 3 Japanese doctors providing care to 8,000 people as a primary point of contact. Not only 8,000 people, but 8,000 people camping in a heat wave. So it was quite challenging for the first 24 hours with no triage. So from the Japanese point of view, what tends to happen is everybody who presents to a doctor gets seen by the doctor. The other thing that was unusual, and I think quite different to some of the work that we would do, is that minor surgery, so to cuts, tears, were provided at the hospital, and patients were dripped. If they were dehydrated and vomiting, they weren't sent to the central hospital in the city. They were dripped in that makeshift hospital. But then you'd have the bizarre situation that a case that we clearly knew was shingles would be sent up to the specialists at the hospital to deal with. So it was quite an interesting place to work. There was some cultural stereotyping on both sides. I hadn't realised my own stereotyping, and I was a bit taken aback about how the European population is stereotyped by the Asian population. There was quite a lot of psychological diagnoses assigned to some relatively ill children. So what was the hospital like? Well, these were our consulting rooms. Confidentiality, which we work so hard to protect in this country, isn't important. It's not something... They do still believe and have confidentiality, but they don't... In this situation, we weren't able to protect it quite as well as perhaps we would have liked to because of the makeshift walls. They have curtains, no doors. Again, it struck me that with the curtains, how easy it was for curtains to be pulled open. You have to be very much aware of, if you're going to do certain examinations, making absolutely sure that some nurse or one of the nurses wasn't going to come running in to your cubicle to see if you needed any help or support. And one of the things that we did do was have to play hunt the thermometer quite a bit. This was the IV room and the observation bay. And I think the thing to highlight that obviously these facilities are quite different than if you went to the hospital. This was set up as a temporary hospital for the scouts and their leaders. One of the problems was that heat exhaustion was a huge issue. As you can imagine, you've got all these children, you've got European children refusing to drink because they don't think they're thirsty in high heat levels. I mean, some days it got to sort of up to 40 degrees or so. It got really quite hot some days, and even the Japanese were saying that they were struggling because it was a heat wave for them. So you had the European children not drinking, and it took about 3 or 4 days for them to suddenly realise if you don't drink, you become ill. And the Japanese quite rightly felt that there wasn't much point to send them to the hospital to put a drip in when they knew exactly what needed to be done. Drip, keep an eye on them, and quite often within an hour or so of being dripped, they would be on their way. What was interesting is that some nationalities did exactly as they were told and sent all the patients up to the hospital, and other nationalities looked after their own patients. And one of the things that it did highlight to me, the importance that if you're working in a different country and you're working with different nationalities, is the comfort of just having somebody from your own unit or that you know or that speaks the same sort of cultural message as you, coming and talking to you and translating for you. And from the point of view of the UK, I had a couple of the patients came in, and the poor Japanese doctor was having quite a lot of problems trying to convey to the patient that this was something that would get better, but they weren't just writing them off as there's nothing wrong with you, because although they had very, very good English, they struggled to put it across in such a way that the patient understood. And And so it highlighted to me the importance of sometimes providing that support, because all it took is for someone to come in who had the right terms to say, this is a viral infection, plenty of fluids, yes, we understand you're feeling quite unwell, hot and shivery, but using terms that the patients understand, everyday terms, that the Japanese doctors may never have had to use in English. This was the minor surgery bay. What it doesn't show you is a toilet sat just here. And the minor surgery went on there. Now, there was some fantastic minor surgery that was done in that, and I was certainly, the skills were unbelievable. And this is sort of all the equipment for the minor surgery. A lot of the IVs were kept here as well, and the patients would have anything from minor gashes to a couple of 5-10 inches long wounds repaired. If they were more serious, then they were taken up to the major hospitals for more repair. Now, in fairness to the Japanese, they had set this up, and yet all the doctors who weren't part of the initial core team were using this as a throughfare. And it struck me I was really quite surprised at how all the different doctors were using this as a major throughfare, despite the fact they know that minor surgery was going on there. So the Japanese had to be quite firm in preventing that from happening. Working off-site, this is a medical team. What's about to happen in the high heat of day is that you will have these 4,000 to 8,000 participants standing out waiting for the opening ceremony. And they may be out there for 2-3 hours. And so this was a team that was out to deal with the cases as they came in. And that first day, I learned a lot about assessing patients and how much we ourselves have developed over the years in the acute assessment of patients, and the advantages it gives us when working with patients. And also a big thing I learned, which the Japanese are very good at, which perhaps aren't quite so good at, is treating heat exhaustion, because obviously that was a major issue that day. From our point of view, we do an initial assessment of the patient before we decide the management plan. Even an acutely unwell patient, we do our ABCD approach. We make sure that we know what it is that's causing the illness. What struck me is that patients would be brought in, collapsed patients would be brought into this sort of outlying medical post, stretchered in, and immediately it would be assumed that they were suffering from heat exhaustion. And I had one case of a patient with an acute abdomen who was having ice being dumped on top of them and started shivering uncontrollably because they were just getting so cold with all the ice on them. But you can understand that. It's because it just comes back to medicine's about your own experience, what you're used to dealing with, what you're used to managing. So again, if I ever go into this situation again, I would certainly make sure that I'm looking after, that I'm aware of the different cases that you would meet, that you wouldn't perhaps meet in the UK, and sharing some of the information about assessment and treatment. So the whole Jamboree site was serviced, which was 1 kilometre by 3 kilometres, was serviced by these ambulances, and these were army medics. So it was, again, very interesting, because what would happen if they had an acutely unwell patient, you'd have these great, huge, hulking Japanese army medics coming running in with a stretcher, getting the patient up on the bed. Initially it would seem quite chaotic, but as with any other first or emergency contact point, it actually isn't. There's a smooth system running through it. But these guys, they quite liked their role in transporting everybody around, and it was good. I did deal with one patient who was taken to the site, and basically she was exhausted, absolutely exhausted. She was a UK patient and was refusing to go back to her site because it was 1 kilometre down the road. And this is somebody who's put her name down to help out on this site, has been told how big it is. And that's, again, when the cultural thing came in, where the Japanese doctor was trying to explain you are just exhausted, and asked for support with that. And again, I just said to her, look, you've got to walk 1 kilometre down the road. And she actually said to me, but I just want to go to sleep. So you're not sleeping in the observation bay. You need to walk out the door. So there were challenges for all the doctors there, and it was interesting how nationalities responded to the different doctors. So, one of the things that we had a discussion with the Japanese and sort of talked about triage. The Americans, Canadians and the Europeans tend to use quite a lot of triage. I'd always assumed that every country knew about triage, and I was quite surprised at the number of places that don't use triage. So we shared information about that. Understandably, initially the countries that don't have triage were quite uncomfortable with the idea of getting sort of a line of people to see the patients first, like ancillary or allied healthcare staff to see the patients and then referring on if it's beyond their remit. But after running it for 24 hours and discovering that they halved the number of patients that needed to be seen by the doctors, they were actually quite happy with it. They were quite keen on it. And also there's other first aid sites we dotted around the Jamboree site, so participants weren't having to walk such a long distance to get healthcare or support. And as you can imagine, children, if they were dehydrated, feeling a bit dizzy, might think, well, that's fine, I'll walk all the way down to the Jamboree hospital. And by the time they get there, they're twice as bad. Whereas if they go to the first aid site and get given a lot of electrolyte water, then they would be a lot better rather than making themselves worse. So this was a site that the participants were on that contributed to the care. As you can see, there isn't actually an awful lot of shelter. If any of the shelter, it's underneath these tents. And some of them that were experienced units built it so there was wind going through the tent, that it could pick it up, keep them cool. Those that didn't know quite so much didn't look at that, and it could get quite hot underneath these, as you can see from some of these pictures here. Sunburn was a common issue. And this was the IST, this is the International Service Team, and they were the ones that had to walk the 3 kilometres mainly to get down to the hospital. And this was washing day on the site. And these tents, some of them collapsed in the storm, unfortunately, and that's why some of them were looking pretty grubby. So this was the site. So lots of water, and the participants were here, and the IST were here. If you were lucky, you could find a place to sleep underneath this dome. There's a veranda that goes around it, and a lot of people ended up sleeping there. Hygiene. Again, something that surprised me. You go to the toilet, you wash your hands. There was quite a lot of international differences in cleaning and using soap and toilets and things like that. And also, at one stage, there was an issue that there was a bit of... a lot of the international service team, despite being told they were going to do it, refused to clean the toilets, and until that issue was sorted, we had quite a few problems. So, how do they get about? Well, how did we get about? Well, I think this is one of the beauties of Japan, is that you've still got a lot of the traditional local stuff. Trains seem to be one of the main types of public transport, and there were some lovely trains that were beautifully decorated like this. Fans inside the trains, I think that just underlines how hot it gets in that country. And then this is a modern station in Tokyo. So, modern and old. So what were the participants doing? Well, they were visiting local landmarks. They were going into nice cool caves. This was the most popular trip, was the cool caves. And at one stage they were climbing Mount Fuji, which was hot and exhausting work. And again, the amount of water that they can get through was incredible, litres and litres of water, and still managing to dehydrate. I think, again, the participants really didn't appreciate, if you don't stop and rest and allow your body to cool off, it's very difficult for it to cool, especially if you don't get into a breeze, and especially how humid it is over there. They went to see local schools, eating out, and obviously the ultimate or the inevitable shopping. So providing primary care, well, as I say, triage was a big thing. Emergency care was quite interesting, because if you were working with a team that knew the ABCD approach, it made life very, very easy. And it really drummed home to me is how important that ABCD approach actually is. Unfortunately, I did observe a distressing resuscitation that really brought home to me the importance of what we do in the UK in terms of resuscitation, in that they had a young child who came in collapsed, unconscious, and they initiated the resuscitation and actually tried to intubate him despite the fact he was coughing. And it took the A&E nurse eventually to come in and say, the patient's coughing, stop trying to intubate the patient, they've got a gag reflex. And it's simply because there wasn't this ABCD approach being taken. Also, in assessing the patient, it brought home to me the importance of, yes, ABCD, but also thinking, what is actually wrong with the patient? Is it heat exhaustion? Is it an acute abdomen? Rather than making the assumption that it is what the most common thing is. Again, it was sort of doctors from the Netherlands, doctors from parts of Europe, doctors from all over the world that had got into this mindset, it's heat exhaustion, it's heat exhaustion. It was so easy to end up in that sort of pathway, and it wasn't until something happened unusual that you suddenly thought, hang on a minute, and step back, I've not actually assessed this patient fully, I've just made this assumption. Prescribing differences, again, dosages, that's the main thing for me. Things like when children came in with either acute vestibulitis or labyrinthitis, which occurred once or twice, we prescribe for that quite easily and freely because we see it as quite a debilitating condition, whereas some other nationalities don't prescribe for that. And it caused a bit of debate. Well, we've got quite a distressed child, what do we do? And there was a bit of lateral thinking going on. In the end, I think we used some medication, cold medication, which the Japanese use, that has beta-histine in it as well. Specialist-generalist divide, that was quite interesting because I think because a lot of the work goes into and presents to the specialists within Japan, and I think it happens quite a lot in the USA as well, is what tended to happen is if they were uncomfortable with the condition, they would look to refer to a specialist, even if it had, like myself and the Canadian family doctor saying, we know what this is something we would normally manage in the community, we're quite happy, we're quite comfortable with that. And this is why a case of shingles got referred up to the dermatologist up at the hospital. And there was a few other similar cases that this happened. Again, I can understand that. It's a discomfort of working without your normal remit. So again, it highlighted to me that actually the generalist role was really quite useful, because once we developed a good working relationship and we got to know each other, this happened less and less. And we managed to look after quite a lot of people without referring them up to the hospital and look after them in primary care. So different nationalities and national stereotypes. As I say, it's quite interesting. A lot of Asia, I think, see a lot of the European countries as having psychological problems. And there was a couple of occasions where the things were labelled, as I say, vestibulitis, very viral conditions, etc., were labelled as psychological. But we also have to watch our own stereotypes. I went out there thinking there'd be more alternative medicine, and there wasn't. There was an awful lot of it was Western medicine, in fact less alternative medicine than we sometimes use. The sick role. There was a huge difference in the sick role across nationalities. Some nationalities, the sick role's a big thing. If you're ill, you need everyone around you should look after you. And also, as well as the sick role, there was also gender differences. Some nationalities treat different genders quite differently, and that was quite challenging to deal with sometimes. Exhaustion. Exhaustion in these sorts of events is huge. Exhaustion of the doctors because they're hot and suffering from the same problems as the participants, but exhaustion having a huge impact on healthcare and on your health as well. I was quite surprised how many of the minor conditions seemed quite major, and actually the issue wasn't necessarily the condition, it was the fact that the participant hadn't slept for 48 hours and therefore was struggling to cope with the problems that they were experiencing. Mutual trust. Again, it highlighted you've got to have mutual trust to be able to work in that environment. You've got to build the relationships with the people that you're working around, because otherwise you'd go and do your assessment and then somebody double checks your assessment, and you get into this thing where everybody's time's being tripled or doubled more than it needs to be. So common conditions to the UK, which the UK and the European countries that you tend to get seen in other places. Dehydration, it tended to be more common amongst the Northern European communities, I suspect, because they really weren't. We told the children until we were blue in the face how important it was to keep hydrated, but unfortunately didn't believe us to start with. Blisters. Tended to be the UK population that presented with blisters. Not sure why. Doesn't make much sense because we've got a very similar climate to some of the other Scandinavian and North European countries. Cellulitis, again, a British thing. I do not know why. If anybody's got any answers to that, I'd be interested to know. Heat rash. Heat exhaustion, again, that was sort of the northern countries tended. And viral illnesses. I suppose, naively thought before going out that viral illnesses occurred equally across the world, but nope. Viral illnesses, the Scandinavians, the Canadians, and myself were sort of viral illnesses. We knew what they were, we were comfortable with that diagnosis. But a lot of other countries weren't because they don't come across it very often. Fatigue was common, strange rashes. There were some very strange rashes that we never got to the bottom of, but responded to antibiotics. And acute abdomens, the number of patients we saw with an acute abdomen, and unfortunately collapse was another thing. But in terms of the rashes, the number of times that the American doctors, the Canadians and that would come to me and say, "You're a British doctor, can you look at that British skin over there, please? We don't know what's going on." So it's quite interesting. So what did I learn? Well, the importance of a thermometer, stethoscope and oroscope. Triage isn't a common concept internationally. North American continents and North European countries have a similar approach to medicine. Initial assessment is absolutely vital. Management pathways are beneficial. I was always aware they were beneficial, but I was sometimes a little bit sceptical of the evidence behind them or how closely we should follow them. I think their strength has increased in my eyes since doing this. Consider low-dose medication when you're treating people from other nationalities who maybe have smaller body mass. It was a real eye-opener to me as to how we were viewed by Eastern countries. I think that's important, and we need to think about why. And actually we provide, despite the problems we have with the NHS, we actually provide quite high-level healthcare within the UK, and I think we should be proud of it. And that's me.